a very new topic which I prepared during my long journey to New York and Atlantic City and then back. There's a saying in English, what gets measured gets improved. When doing OB ultrasound, we do biometry, which includes everything like this, and I'll not go into the details. Heart size, 4-chamber, cerebellar, amniotic fluid index, placental thickness, and so on and so forth. When doing the gynae study, we do the following measurements, but I'm going to tell you something very informative. Endometrial thickness, ovarian volume, seedling fibroids, and so on and so forth. PCO, follicular size range, what is this? I'm going to talk about numbers. SAC not corresponding with LMP, missed abortion or blighted ovum, and we must know the size of the sac and the ratio. So here is a patient where we see the sac, but a very teeny tiny yolk sac, which is telling us that it is less than, which is more than 1.5 ratio. We always talk about ratio, we'll get more information. CRL to SAC ratio, what do we mean by WNL, is within normal limits, smaller or bigger, and that will determine decreased amniotic fluid or increased amniotic fluid. So here is the sac with a fetal pole, and we can see the fetal pole with the sac. If it is 1.5 ratio, that's fine. If the ratio is disturbed, we are dealing with a very early sign of miscarriage. Yolk sac, anything more than 0.6 centimeters, has been documented that it is a bad outcome. So here's a normal yolk sac, and here is a yolk sac which measures 0.8 centimeters. It's a bad sign, a bad outcome. Corpus luteal cyst, what do we mean by these numbers, 3, 5, 7? If you see a corpus luteum within that 3 centimeters mean diameter, everything is fine, nothing to worry about. When you see 5, 7, it may turn into an ovarian cyst, and this is a patient which needs follow-up every 4 weeks. When we come to CRL formula, very easy to remember. It's 1.2, 2.2, 3.2, 4.2, 5.2, and that correlates very well with the gestational age, and you don't have to look into the chart. If you ask me, when did I look into the charts? 25 years back. I've been practicing for the last 33 years, and for 25 years I've never seen a chart because I've developed my own charts, and that's published in the International Journal. So here is the, thank you very much, the CRL, crown rump length. Don't blame me if you take the wrong CRL. If you take axis rotation of your probe and get the maximum length, that is the accepted length of the CRL. What about translucency, nuchal translucency? Any nuchal translucency more than 0.3 centimeters, we are thinking in terms of Down syndrome, and we need to follow that patient or do free beta HCG or PEPA. If it is greater than 3.4, add cardiac problem as well at a second trimester level. The nuchal translucency can be viewed, and I beg to disagree with Kypros Nicolaides that you have to see from the front. You see nuchal translucency much better from the back. It's more accurate, and try that. Every one of you can do that. And the reason is that at the back we have got the amnion, which can be mistaken, and I've seen lots of reports amnion being reported as nuchal translucency, very dangerous. Anybody see that lucency? And the answer is no. So what do you write? No evidence of nuchal translucency. You don't measure anything because there's no fluid collection at the back of the neck. And when there is no dip, that's what we want. So here we can do the endovaginal, and we can get the nuchal translucency as early as 10 weeks. And if you see thin septations, let me enlarge it for you. If you can see these thin septations within the nuchal translucency, you are dealing with cystic hygroma as early as 10 weeks. There's no need to keep this pregnancy. When we start to measure the nuchal translucency, we don't measure the CRL after 12 weeks. We measure the BPD because by that time BPD is well versed and everybody can see a beautiful image. What about nuchal fold thickening? What is within normal limits and what is large? And large means underlying chromosomal abnormality. So here we can see the AP diameter of the nuchal fold thickening, and if it is more than 1.3, that is a sign of underlying chromosomal abnormality. We call it subtle sign of underlying chromosomal abnormality. Now coming to the nasal bone, I agree with Kypros Nicolaides that if you see absent nasal bone, it's a high risk that it is an underlying chromosomal abnormality. But when it is present, or when we measure them, anything less than 1.3 centimeters is a Down syndrome baby. So here you can see the curvature of the frontal bone, and with that you see this nasal bone with that of tip, and that is of course the normal nasal bone which you have to measure, and it should measure 1.3. This is our new director, Professor Levon Azaria, who is now taken over from Dr. Barry Goldberg. Let's talk about BPD, biparietal diameter. What is within normal limits? What do we mean by small and what do we mean by large? I'll not go into and waste your time explaining everything. The slide is right here, and that's what we pick up in abnormalities. Taking the correct BPD is very important with all the landmarks, and I'm not going to describe that. The BPD formula is very simple. Whatever the gestational age multiplied by 4 will give you the gestational age, and that is very accurate, plus minus 1 week. When it is 6 BPD multiplied by 4, 6 4s are 24, 7 4s are 28, 8 4s are 32. The joke is that एक उस्ताद ने बच्चे से कहा कि 2 का पहाड़ा सुनाओ, तो उसने कहा पहाड़ा तो याद नहीं है, 2 की धुन याद है, 2 का so in case you forget the multiplication of 4, please remember the pahada. Cephalic index is within normal limits or not correct for BPD. Many of you do not even know what cephalic index is. It's a BPD divided by OFD multiplied by 100 and you get a number. Anything less than 73 or more than 74, it's 84. It is dolichocephalic or brachiocephalic, which is not meant for taking the BPD. What about HC formula? If the head is oblong, if it's rounded, is it abnormal or it is within normal limits? And that you have to check with the HC. So what is the formula? You take the correct, you take the BPD where you take the BPD and where you take the circumference on it and then feed into the formula. Whatever the gestational age minus 2 is the head circumference, and remember, Dr. Khalid said, if you want to smile at the mirror, you will see your own smile. Well, everything is based on reflection. पूरी कायनात का वजूद जो है वो रिफ्लेक्शन पे बेस्ड है. It's a very important thing. So in this slide I've meant that if you minus the gestational age minus 2 and if you add 2 to the head circumference, you get the gestational age. It works both ways. What about the femur length? If the femur length is short, is bowing, is less echogenic, within normal limits, small or large, how do we know that? Femur length plus 2 multiplied by 4 will give you the gestational age. What do we mean by that? Whenever you have femur length, you add 2, it becomes BPD. and BPD multiplied by 4 will give you the gestational age. Very ready reference formula to check whether the BPD and femur length are in conformity with each other. So here's the femur length, and I'll not waste your time on that. Here's a microcephaly because the femur length is bigger, is 4 centimeters, and the BPD is 3.8. Something is going wrong terribly in this picture, and you take side by side and make the diagnosis. Here the femur is too small, BPD is 7. 7 minus 2 should have been 5. Instead of 5, it is 2. That means the femur is beyond that limit. What about the AC? Within normal limits, small or large, IUGR, organomegaly, macrosomic baby, height drops, and so on and so forth, which you already know, so I'm going to skip that slide. How do you take the abdominal circumference, the J-shaped configuration of the umbilical vein with that of the portal vein, and the formula is very simple. Whatever the gestational age minus 5 is abdominal circumference, and it works the other way around as well in order to know that. The body is smaller in the first half of the pregnancy, BPD is bigger, and it changes after mid-pregnancy. Here you can see the body is bigger with a cyst, and this is what is called as megacystis, which is an underlying chromosomal abnormality. You may terminate this pregnancy at this stage of pregnancy, at this stage of gestational age. What is OOD? Outer ocular diameter within normal limits or large, small, and that tells us about the underlying chromosomal abnormality, hypotelorism or hypertelorism. So that's normal. And what is the formula? Whatever the OOD multiplied by 6 will give you the gestational age. If that gestational age correlate with BPD, there is no hypotelorism, no hypertelorism. If not, think about the chromosomal abnormality. And this is the orbits too close, and this is orbit too wide. You already know that. Cisterna magna within normal limits, Danny-Walker malformation, fourth ventricle dilatation. Very ready reference formula is right here. If you see nuchal fold, cisterna magna, atrium of the lateral ventricle, fetal hydronephrosis, whatever between 25 and 30 weeks, it should measure 0.5, it should measure 0.7, 0.9, and that's a very ready reference formula. So here is the cisterna magna, and here is the cisterna magna which is dilated, and here is the nuchal fold thickening. Anything more than 0.5, 0.7, 0.9, you're dealing with the problem. And when you see the fourth ventricle dilatation or cisterna magna dilatation, of you call it if you see this dipping in right here without that echogenic, the vermis is absent. The first thing which dilates in lateral ventricle is the atrium of the lateral ventricle, and the same formula works very well, 0.5, 0.7, 0.9. And that is what we are going to diagnose with either the measurement is 1/3, that you measure the falx to the calvarium, and if it is 3 centimeters, this lateral ventricle should be 1/3 or less than that. That means there's no hydrocephalus. Renal pilactasis, UPJ, or chromosomal abnormality. How do you make the diagnosis? You scan in such a way that you see the spine at the back facing the probe, and you see the triangular area which is hydronephrosis, and you measure the edge where the shadowing is, and that should be 0.5, 0.7, 0.9. Third ventricle and duct dilatation, aqueductal dilatation, right here you can see that, and that's the fourth ventricle dilatation. Heart size ratio within normal limits, cardiomyopathy, and what is the way to do it? You take the circumference of the chest when you have obtained the fourth chamber view, and then you draw another circle, the circumference on the heart. Anything 1/3, normal. Anything is not 1/3, it's either small or large. Heart axis deviation, if it is, we call it levocardia normal. If if it's extreme levocardia, or if it is dextrocardia, or if it is mesocardia, then we have to think about the abnormalities in the heart. HLHS, hypoplastic left heart syndrome, is very common, large ventricle or small right atrium. And that's how you measure the heart axis. 3-vessel view has to be included in your routine obstetrical ultrasound, pulmonary artery, aorta, and SVC. What is the trick? And the trick is you measure the pulmonary artery. If it is 0.6, the aorta should be 0.5, and the SVC should be half of pulmonary artery. That's normal. If any discrepancy in that, you're dealing with the heart problem, and you have to go for the fetal echo detail. How many of you know about the hockey sign, the Pakistani hockey sign, and the Dr. Fazil is smiling because he told me the other one is called the ice hockey sign. So that's the ice hockey, and that is the Pakistani hockey sign. If you measure from the chest to the back, the hockey should come in the center. That means outlets are normal. Renal size within normal limits, smaller, large, agenesis, polycystic, and whatever the gestational age, add 5, put a dot, that should be the length of the kidney. If that kidney is bigger, why it's bigger. If it's smaller, why it's smaller. So here is the kidney of the fetus. Placental thickness has been spoken of. Very easy to remember the formula. At 15 weeks, put a dot, it should measure 1.5. 13 weeks, put a dot, 3.0. And it is always the range. In medicine, there are no absolute values, so you have got range from 0.7 in these. So placental thickness would pick up either IUGR or PIH. Our eminent speaker from Thailand spoke about, and high drops, drugs, diabetes. So we have to measure the thickness of the placenta in every patient, and that's a thick placenta, and that's a very, very thin placenta, pointing out to the abnormalities. Uterine wall thickness should measure at any time of the gestational age, 0.5 to 1 centimeters. Less than 0.3 centimeters, you get to worry about. Dr. Khalid spoke about the thinning of the uterine wall. So right here is the placenta, and I'll skip placenta because it was spoken earlier. Cerebellar diameter within normal limits, or small banana shape underlying chromosomal abnormality. Whatever the cerebellar diameter, 2.2 centimeter, remove the dot, becomes the weak, provided that you know that you've taken the correct cerebellum. So the cerebellum, everybody knows, right here, rounded and from edge to edge. AFI, I beg to disagree with Phelan's classification. I have done my modification and I've published that. Age 9 to 19 is normal. Increase or decrease are we looking for, and we talk about these terminologies: slightly decrease, moderately decrease, or markedly decrease, and so on and so forth. Why? Because we did a study, and I'm not going to waste your time on my study. Phelan's classification gives a bigger range because of the United States. They can be sued in the court for wrong diagnosis, and we have limited our. So amniotic fluid is 14 plus minus 5. 5 is 5th percentile, and plus 5 is 95th percentile. So 9 to 19 is normal. Minus 3, slightly decreased, moderately decreased, and markedly decreased. And slightly plus 3, slightly increased, moderately increased. And I'm not going in the details. Increase amniotic fluid, why you want to make that diagnosis? Because you have so many problems to diagnose, and always bring your color Doppler in to really see which one is the cord and which one is the fluid. Decreased fluid, ruptured membrane, leaking membrane, IUGR, PIH, drugs, urinary tract. And this is a panoramic view to tell us that there is no amniotic fluid, because you can pick up the entire fetus along with all the structures. That's why before 18 weeks of pregnancy, I would still go for eyeballing technique for increased or decreased or adequate amniotic fluid. Cervical length within normal limits or small incompetent. I'll just show you this slide. The cutoff point is 2.6. According to the FIGO, it's 2.5. Doesn't matter. It's just a point difference, but that's what we take. I'll skip the top proportion because of the time constraint. I'll just come to last few slides because of the time constraint. Anterior abdominal wall thickness. I don't know how many of you measure anterior abdominal wall thickness in every patient. If I see the abdominal thickness, anterior abdominal wall thickness of the patient who is either pregnant or having the gynae study more than 3, I call it the poor resolution. I'll always start with the sentence, technically difficult patient to scan. And anything which is less than 1 centimeters is a good resolution. Try that when you scan. Uterus size, normal, infantile, and enlarged, that you already know. Canal thickness less than 0.5, taken as normal. But be careful. Are you measuring? If it is trilaminar, it's a different story. But if it's a thick canal, do you divide it by 2 or you measure the whole thickness? And 1 to 3 is the normal, and anything 1.5 to 2.5, you're dealing with a thick canal. Ovarian volume is 8 centimeters cube, is less than that is normal, 8 to 12 borderline, gray shades, anything 12 centimeter cube, that is an enlarged ovary. Follicles, a very new slide with my work. Antral count measures 0.3 to 0.5. Follicles in PCO should measure between 0.5 to 0.9 centimeters. Mature follicles 2.3 plus minus 0.5. That means mature follicle can rupture as early as 1.8 and it can rupture as late as 2.7 or 2.8 centimeters. Follicular cyst is defined by 3.0 to 5.0. Why we need to call them as retention cysts? Don't do anything. Don't write it cyst. Write the follicular retention cyst, otherwise they might be operated. Ovarian cyst, which needs follow-up, 5 to 7. Ovarian cyst, which is 7. Mean diameter needs aspiration. Very nice view of the PCO. PCO, lots of people have done it, but I'll just mention one point. People talk about follicle, periphery. Time is over. Please, time is over. Give to the world the best you have, and the best will come back to you.